Hello and welcome everyone. Thank you very much for joining us today. And I again wish to thank you for your interest in this education course. And we will be starting in 3 minutes from now. So I will like to say a couple of things before we start. First of all, I'm really honored and pleased to collaborate with the PSN and the NMU, PSN, the Pakistan Society of Neurosurgeons and National Medical University for this course. I'm Dr. Noor-ul-Huda, and many of you already know about me, and it's basically collaboration that I have made through news with PSN and NMQ. So I'm so much happy to do this very amazing course, and I'm also so much pleased to introduce Professor Nobutaka Hori Sensei Hori. Thank you very much for joining us today. We know you so well, and with my special interest in stroke intervention, I have gone through many of your papers and also in not only in stroke intervention but also in other endovascular, the research work and everything. So I'm a huge fan of yours. Thank you very much for sparing time on from your very busy schedule and on a Sunday. And to all of you, just for the sake of formality, I want to introduce Professor Nobutaka Hori. He is the professor of neurological surgery at the Hiroshima University, rather the very prestigious university of in Japan. And he's also a Stanford alumnus, and he's a very prolific researcher. And I really wish you all to go through all his wonderful work, which is available on the internet. And I have the honor of going through his work myself. So, sir, it's a pleasure to welcome you today to our webinar. This is the preparatory course that would be leading to the NASSIC hybrid conference that will be held in person in November. So again, thank you so much, sir. And for every attendee, this course is free of cost to attend. So please feel free to invite your colleagues and friends to attend the course. Sensei Hori, thank you very much for joining us today. The floor is all yours. Please take as much time as you like. We will take a couple of questions at the end of the session. If you kindly spare a couple of moments, I can very well understand your very busy schedule, and I'm so grateful to you. Thank you so much, sir. The podium is all yours.
Thank you. Good afternoon in Japan. So it's a very good honor to have the presentation in this web conference. I'm the Nobutaka Hori from the Hiroshima University, chairman of the Department of Neurosurgery. You know, the Hiroshima is very famous for the historical. So
And
it's
congratulations, sir, congratulations on bringing home the Nobel Peace Prize yesterday.
yeah, it's a hot topic here. Thank you very much. So the now the I have the we have the 1 hour lecture. So let me start the presentation. Can you hear me? Okay.
Yes, sir, everything is perfect. Thank you so much.
All right. So today I'm gonna talk about the management of the ischemic stroke. It's a very the wide field to talk about the ischemic stroke. So today I'm gonna talk about the current topics and the management regarding ischemic stroke in Japan. So this is a COI. So in introduction, the stroke is a leading cause of death and its ability globally understanding its management is crucial for improving the outcome. The ischemic stroke accounts for 85%. Most of all strokes, hemorrhagic stroke make up the remaining only 15%. So advanced imaging techniques are essential for selecting the appropriate candidate for thrombectomy or surgery. So I hear that stroke incidence varies globally. In Pakistan, the burden is particularly high with limited access to advanced care. So today, I want to talk about these three topics. The first one is uh, acute major vessel occlusion, AIS. And the second topic is extra vascular stenosis, especially the cardiac stenosis. And the last one, I'm talking my research team regarding a future direction for stroke, especially the cell transplantation therapy for the ischemic stroke patient. This is the number one, the acute major vessel occlusion. We have a lot of evidences regarding the thrombectomy for the major vessel occlusion. The first one came in 2014, Mr. Green. It has been, more than 10 years since Mr. Green published the paper. So at that time, the indication for the treatment of thrombectomy for the AIS is the onset within 6 hours, and the neurological deficit NIH stroke scale is 6 or above. And the aspect score based on the CT or MRI is above the 6. And of course, the patient is 18 or more older. The location is the ICA occlusion or proximal A1. And using the stent retriever at that time. So this is a meta-analysis for the thrombectomy. Published in Lancet. This is a very surprising message. You can see here, the number needed to treat with endovascular thrombectomy to reduce disability by at least one level on modified Rankin scale is 2.6. This is a quite surprisingly low number. So for such cases, we must do the thrombectomy for the patient care. After that, the indication is expanded. From the evidence published from Dawn trial or the Diffuse 3, if the patient comes more than 6 hours from the onset, we sometimes do the thrombectomy for the patient based on the imaging the result. So this is a Japanese guideline to do the thrombectomy. You can see this graph. The one parameter is the time from onset. The another one is the ischemic core. So if the patient comes within the 6 hours from the onset, and also the ischemic core is under 50 millimeter volume, we should do that. This is grade A. So first, it is very important to find the patient for candidate. So this is imaging shows the early ischemic sign in the patient showing the major vessel occlusion. You can see these four slides. The A is obstruction of the insular cortex. The B is the disappearance of the cerebral sulcus. C is obstruction of the narrow boundaries. And D is cerebral edema without reduced cortical absorption. With these findings, we calculate the aspects. So if you can find the abnormal area, you can reduce the point. So the 10 is the max. If the count score is low, the patient has a very severe impact area. You can also find the damaged area with diffusion MRI imaging based on the diffusion weighted image. This diffusion DWI shows the irreversible the ischemic area. So you can see the white area. This is already the damaged. So we can also the count the aspects with MRI imaging here. Sometimes another sequence with MRI shows the important the information regarding the status of the ischemia. So in this the figure, the picture, you can see some the white intensity area in the affected the hemisphere, left hemisphere. This patient had the left internal carotid artery occlusion and the flare sign. Uh, we call this the high intensity area in the artery is intra-arterial sign. This means the collateral supply from the ACL or some left meningeal supplies from the another side. So if you can find this the intra-arterial side, this means that the patient has the major vessel occlusion without showing the MRA imaging. Sometimes we can check the status of the collateral flow from the ASL. ASL very specialized the technique in MRI, estimating the cerebral blood flow. This is not quite the same, but you can estimate the cerebral blood flow in using the ASL imaging. This patient has the right M1 occlusion and the ASL imaging. You can see that the low signal in the right hemisphere, and also you can find it is quite hard to find, but you can see the red spot here, this is arrow here. So this means the stagnation of the blood flow. Also, you can find the when you find this spot, the patient shows the major vessel occlusion without checking the MRA. Also, the it is very important to check the status of the patient with echogram. So I will show you some patient to showing the significance of the carotid echo. We perform this carotid ultrasonography within 5 minutes before thrombectomy. It is very important here. This patient is the 86, very high age, although male with pacemaker. So we cannot perform the MR imaging for this patient. This patient showed the disturbance of the consciousness, total aphasia, and the complete paralysis on the right hemisphere, right upper and lower extremities. And the onset to door is 5 hours. Checking the CT scan, you can see some blurring of putamen and caudate nuclei, but it is hard to see the status of the vessel. The right picture, hyperdense MCR sign or not. This is equivocal here. In this situation, we always perform the carotid echo ultrasound. It is easy to see the major vessel occlusion. If you find this kind of the to and fro pattern, this means that the intracranial artery stenosis, carotid artery occlusion. So you can do the diagnosis of the major vessel internal carotid artery occlusion without performing CT or MRI or angiogram. This is another case. So this patient saw the dissection of the common carotid artery. You can see the flap here. So I'm sorry, this is a Japanese term, but you can see the flap here, and this is a red area is a true lumen, and the gray area is a pseudo lumen. This is a very terrible situation. In this case, it is very you should not perform the TPA injection or perform the thrombectomy. This is a contraindication for TPA or thrombectomy, and it is very, carotid ultrasound is very effective to check out the patient. So this is another case. This is actually the cardiac ultrasound. So the right image movie is during the TPA injection, and the right movie showed the 15 minutes after the end of the intravenous TPA injection. You can see something here in the TPA injection, but 15 minutes later, it is completely disappeared. What is going on? Maybe this clot went out to the some area, maybe the brain or maybe another the organs. And this patient, we performed the cardiac ultrasound 3 days after TPA therapy. You can see the clot again here. We found that the hyperdense mass is a cardiac tumor. So for this patient, we performed actually we did not. So cardiac surgeon performed the removal of this kind of a tumor. This is quite rare, but sometimes you see this kind of the situation of the patient showing the major vessel occlusion due to this cardiac mass. Again, in the major vessel occlusion, the time is brain. It is very important. So to save the time, we can also check some software evaluating the status of the brain and also evaluating the several perfusion. You can see the rapid or Vittoria or PMA. This is a one sample of the rapid. Rapid is a very easy to see. The automatically define the ischemic core based on the CBF under 30%. And also you can find the ischemic penumbra based on the Tmax over 6.0 seconds. This patient shows the ischemic core with 13.1 millimeter, and the ischemic penumbra is 73.9 millimeter. So the mismatch ratio is 5.6. So this patient, we did the thrombectomy. Also, you can find the degree of the collateral supply using the rapid, especially the calculating the Tmax over 10 seconds divided by Tmax over 6 seconds. If the we can call this hyperperfusion intensity ratio, HII. And if the HIR is very high, the patient shows a very poor collateral supply. It's a very high risk for the uh, cellular infarction. We can do the angio machine to do the thrombectomy, of course. And the current angio machine can perform the rapid analysis. If you can use this kind of the machine, you don't need to analyze the hemodynamics or ischemia or penumbra with CT or MRI. So sometimes we transfer the patient directly to the angio suite and perform the rapid and if the patient has a candidate for thrombectomy, we perform that. In this situation, we save the time and very, quickly we can do that. Uh, Pathology of the major vessel occlusion is also very important. The most of the major vessel occlusion is from the AF, arterial fibrillation, in the, arrhythmia. So if the patient shows a major vessel occlusion with cardiac origin, you can see find this kind of the low intensity band in MRI. This means that red blood cell rich clot. It means the cardiac origin. This is another paper. The right figure shows the ICAD. ICAD is a intracranial artery disease, atherosclerosis based. And the right one is the embolic stroke, cardiac embolic. If you do the angiography, the ICAD patient shows this truncal type occlusion here, but in the patient showing the cardiac embolic stroke, the imaging shows the branching site occlusion here. So the occlusion point is slightly different from the carotid stenosis, arteriosclerosis, and embolic stroke. So it is helpful to distinguish with the atherosclerosis from the cardioembolic. Atherosclerosis patients often shows the calcification of the vessel wall. So if you see the CT imaging carefully, sometimes the patient shows this kind of the very dense, hyperdense area on the vessel wall. This means the atherosclerosis. So this is very helpful to check the status. So now we have a lot of devices to perform the thrombectomy for the patient. Maybe sometimes the fibrin rich and sometimes red blood cell rich. So we should choose the devices for the thrombectomy. So if the clot is red blood cells, composition of mainly red blood cells, it is a soft clot. So maybe the stent retriever is very effective to engage the clot here. But the clot is mainly fibrin-rich clot. it is difficult to capture the clot with stent retriever. In this kind of the situation, you should try the aspiration catheter to take it out. Now we have a very published a very big evidence regarding the thrombectomy for low aspects. Generally, the if the patient shows the low aspects, the nobody know that the effectivity of the thrombectomy, but we found that published in the New England Journal of Medicine. So if you have a severe infarction under aspects 6 or maybe 5, 4, or 3 or something, so it is very if it is very early from the onset, its activity performed the less activity performed thrombectomy. If the even if the patient shows the low aspects, the final clinical outcome is better compared to that without thrombectomy. But very severe case, let's say the aspects under 3, 1 or 2, 0 or 1 or 2, the result is same. So the very, very severe cases with aspect under 3, we could not find any merit performing the thrombectomy. Sometimes we perform the thrombectomy for the distal area. We call this location MIBO. Sometimes including the M2 or M3, middle cerebral artery. If the patient show the MIBO with eloquent area, or let's say the motor or sensory or the bulbar area, we do perform the thrombectomy. But in this distal area, of course, IVTP is sometimes effective. About 37 to 42% of the case with resulted in the good recanalization without thrombectomy. So this is a very comparative. Basilar artery occlusion. So the patient shows a basilar artery occlusion. The neurological score is very, very severe. And also you fail if you fail the recanalization, the clinical outcome is quite poor. So in this case, we also perform the thrombectomy. This is a published paper from the China. And also this is a published from the China, Bauscher investigators. So these two papers established the efficacy of the thrombectomy in basilar arterial occlusion as well. So we can use the many kind of the devices, stent retriever or the aspiration catheter. But it is very important to keep these 3 points performing the thrombectomy. One is one prosthetically. Second is early recanalization, and third is safety. So in Japan, we perform the combined technique, almost all the cases, stent retriever with aspiration catheter. I did say that the clot character is very important for the efficacy of the thrombectomy. If the clot is like fibrin-rich clot, this is difficult to be incorporated into the stent cell. This is a good candidate for the aspiration catheter. And on the other hand, if the clot is the soft clot based on the red blood cell like E, this is a very higher risk of clot stripping or fragmentation using the central retriever. Also, the vessel curvature is very important. Sorry. Vessel curvature is very important. Sorry. The curvature is very is a key to get a good recanalization. You can see here the in this situation the stent retriever itself is not so effective to engage the clot here. And again, I would say that let's try to get the clot recanalization with one pass, not a second or third or three. The result, why? This is, I'll show this the movie again. I will taking the clot with the stent retriever, but failed finally. After the fail of the first trial, you can see this clot after the stent retriever removal. You can see the clot shrinked from the original one. If you fail this the one pass trial, you have to try to get this shrink the clot. It is very difficult to take it out. So if you try the second or third or fourth the thrombectomy, the technical success getting lower and lower. So let's try to take a clot in with the first pass. So again, we do perform the combined technique to get the clot. Let me try to show you the some patient. This patient shows a 74 male, NH stroke scale is 7, and the aspect is 8. You can see some the ischemia on the parietal area and frontal area here. But MRI imaging, you cannot see any occlusion of the major vessel. But if you check the MRI carefully, you can see some defect of the signal on the petrous portion of the carotid artery. So we perform the angiogram first. This is the left internal common carotid artery angiogram. This picture shows the something white band here from the carotid bifurcation to the petrous portion. This is a clot originating from the carotid stenosis here. This is not embolic stroke, but the atherosclerosis origin. So in this patient case, we also perform the thrombectomy with combined technique. This is a balloon guiding here, and we put the embotrap. This is a stent retriever here, and aspiration top of the microcatheter, aspirin catheter is here. After taking the clot out, we can see the very nice cerebral blood flow without any white band here. After that, following the thrombectomy, we perform the carotid stenting to the this area, like this. This is another case, 95 male. This is quite a high patient. NIH stroke is 17 and the aspects is 9. You can see the diffusion imaging high spot on the right hemisphere here, and the MRI imaging show the internal occlusion of the internal carotid artery. We perform the thrombectomy for the patient. So this is a angiogram from the contralateral side. Uh, Contralateral intracoronary carotid artery here. You can see some MCA flow from the ACOM here. So we estimated for the patient, the clot is located on the ICA only. This is a right internal carotid artery angiogram. Of course, the right internal carotid artery is occluded with clot. So we navigate the microcatheter beyond the occlusion site. The microcatheter is located on the M1 here. After taking the clot with the stent retriever, you can see a very nice the long clot here. This is the second topic, the extra vessel stenosis, focusing on the carotid stenosis. Of course, the carotid stenosis, based on the atherosclerosis from the hypertension or diabetics or hyperlipidemia or something like that. Currently, we can see some unique patient showing the stroke without any stenosis on the carotid side, bifurcation. This patient shows the right side the hemiparesis or the speech disturbance, but you cannot see any stenosis on the MRI imaging. But if you check the MRI carefully, you can see some white band outside the internal carotid artery lumen. What is this? If you check the MRI source image carefully, you can see this white band outside the carotid artery. This is the plaque. So this patient showed the artery-to-artery thrombosis from this carotid plaque without severe stenosis. So we need to focus on the plaque stability, stable or vulnerable, to see to manage the ischemic stroke. This is a remodeling of what atherosclerosis regions. This is advanced. So you can see some the plaque outside the lumen. This we call this positive remodeling. But uh, in sometimes the plaque advanced into the lumen. We call this a negative remodeling. So we used to perform the reconstruction surgery for this kind of the negative remodeling, but sometimes the patient shows the A to A occlusion from the positive remodeling without any stenosis of the lumen. So the presence of the unstable plaque, even in the absence of the narrowing of the lumen. So we need to fight against the vulnerable plaque. regardless of the stenosis degree. So now in Japan, we always focus on the character of the carotid plaque, sometimes repeat or sometimes hemorrhage or sometimes the calcification. So among the some character of the carotid plaque, intraplaque hemorrhage is very important. This paper shows that the intraplaque hemorrhage is a strong indicator for the recurrence of the stroke, regardless of the stenosis. Even if the stenosis under 50%, intraplaque hemorrhage is a higher risk of the recurrent stroke. 50 to 69 and more than 70, the result is the same. So we need to really focus on the intraplaque hemorrhage. So this is another case. The intraplaque hemorrhage is an independent risk factor for the stroke. This is the intraplaque hemorrhage. This is a repeat, and this is a calcification. You can see the very big difference between the two, absent and present. So again, we need to focus on the intraplaque hemorrhage. For this, the carotid stenosis, we can perform two choices. One is a carotid artery stenting, and another one is a carotid endarterectomy, direct surgery. Carotid artery stenting is less invasive. It's one of the catheter treatment. So the number of the penetrate CAS patient is gradually increasing. On the other hand, the patient performed the CA is stable. This is a Japanese trend. But sometimes we, of course, perform the carotid and endarterectomy for such a vulnerable plaque. Now I am performing the endarterectomy for the patient. This is the carotid artery here. This is a bifurcation. This is the ICG. I'll skip some movie. So now I'm taking the plaque. This is quite a vulnerable plaque. You can see some, uh, dark spot. After taking out, I will close the vessel. So we mostly perform the carotid artery stenting for the patient, but sometimes, and carotid endarterectomy is effective for such cases with intraplaque hemorrhage. But now, the medication is very advancing. The result of the medical therapy is getting better and better. And sometimes this paper shows that the compare the carotid intervention versus medical treatment to prevent the stroke in asymptomatic carotid stenosis. Actually, this paper showed that the result uh, of the carotid artery stenting and medical therapy for asymptomatic stenosis more than 70% degree, result is quite the same. So these patients are asymptomatic, so we need to care about maybe sometimes medical therapy is enough to prevent a stroke for this kind of the asymptomatic carotid stenosis. This is the last topics, future directions of stroke, especially focusing the cell transplantation. This is some the movie shows the cell therapy for the patient with the stroke. Actually, the patient get their cell transplantation. Before the treatment, you can see severe right hand paralysis. But after that, you know, remarkable improvement after the treatment. So this is a champion case, but I believe that in the near future, uh, we can add this kind of the stem cell treatment for the stroke. In the near future, I hope that the stem cell therapy through the microcatheter. Let's say the after taking the clot out, you can deliver the stem cells to the through the microcatheter to the damaged area. This is very, feasible, I guess. The recent clinical trial showed that this is a phase 2. They performed the stem cell injection for the patient after the clot removal with the stent retriever. Unfortunately, the result is not so good, but they show that this treatment is safe. And of course, the safe and less adverse events. So maybe we need to perform some other clinical trial. So this is very promising, I guess. In Japan, we are trying some clinical trials of cell transplantation for the stroke patient. Sometimes the acute chronic stage and sometimes subacute, sometimes acute stage. Actually, in my hospital, Hiroshima University, we performed the mesenchymal stem cell from the skull. I'm not sure how many the neurosurgeon are checking this lecture, but you sometimes get this kind of the piece of the skull uh, from the surgery, and after you incubate the bone piece, you can establish the mesenchymal stem cell like the cells. This is skull-derived mesenchymal stem cells. So we check the character of the skull from derived mesenchymal stem cell, and actually these cells express some interesting factor, snail P73 or slug. This means that the mesenchymal stem cells is from neural crest stem cells origin. So using this skull-derived mesenchymal stem cells, we did some animal study. This is a spinal cord injury animal model. After you inject the skull-based stem cell, the cavity is much smaller. So the spinal cord injury improved after the injection of the skull-derived stem cells. Of course, we perform the same treatment for the stroke rat animal. After inject, you can see this is a behavior test. Red is a skull-derived mesenchymal stem cells, and blue is normal stem cell, and black is normal, control. So you can see the very nice improvement of the NH stroke score compared to the two groups. So this is also a promising result, and now we are performing the clinical trial for the patient using this very unique skull-derived mesenchymal stem cells. So I did talk a lot, and this is my conclusion here. The surgical management for ischemic stroke is advancing, especially endovascular treatment. And pre-hospital triage and the local medical care system is very important for the clinical outcome. Hopefully, stem therapy could be a promising therapy for neurological impairment. Thank you for your attention.
Thank you very much, sir, for this very comprehensive and very insightful lecture. And I believe that everyone who has seen it either through Zoom or through my YouTube channel live must have really appreciated it because I have received a lot of messages of appreciation. Sir, thank you very much for your very wonderful talk and the most of it for spending time for this educational activity, which reflects your dedication towards promoting more education and training. So thanks a lot. And for there's some important thing that I really wish to acknowledge at the end of this session, and I've been waiting for it, is that I really wish to acknowledge the resilience and the bravery of the people of Hiroshima and Nagasaki who, gone through such a rather such an experience, such a huge experience. And I believe the Nobel Prize reflects how much resilience they had. And I also have a belief that this Nobel Prize will help everyone to realize that we need more peace in the world, and war is not a solution to anything. And I personally and from on the behalf of everyone in Pakistan, really wish to acknowledge the sufferings and then how the rise of the Japanese people after this incident, and it is really a huge example for every one of us, while it also reflects the need of promoting more peace. So thank you very, very much for this very insightful talk. Sir, I believe that would you like me to say a couple of to convey a couple of questions to you? You had a wonderful talk today.
Okay, sure.
Thank you very much, sir. Sir, first of all, I really want to thank you for all this wonderful things that you have shared and so many points that you have touched. Sir, regarding your very interesting points about stem cells, sir, there is some other research on the subventricular zone astrocytic cells that do have the potential of regeneration, especially that has been seen in the rodents and also in vivo trials, in where they could actually multiply. So do you have that experience, or any what's your insight on those subventricular astrocytic stem cells?
Actually, it is very difficult to prepare the stem cell in the acute stage. You know,
Yes.
we prefer to use the patient original stem cells. So
Yes.
if you can perform the stem cell therapy in the acute setting, maybe you need to use the cells from other guys. So it sometimes causes immune problem. So that's why we prefer the actually in the clinical trial, I do the stem cell transplantation in the chronic stage, 2 months after the stroke. 2 months is enough to prepare the enough cells, but maybe 2 months is maybe too long. I don't know. I'm not sure.
No, no, that's amazing, sir. Actually, I came across the study on subventricular zone, astrocytic cells that have been found to have some potential theoretically, but they were not quite, they have not been really evaluated. And that was an interesting trial to see that there was a ribbon of astrocytic cell that could be potentially, could generate. So that was very interesting. So thank you very much, sir. There is also a topic of great interest nowadays. It is of the pediatric ischemic stroke, sir. Do you really believe that the pediatric ischemic stroke is on the rise, especially after the COVID-19 pandemic? And also, what is your kind suggestion and insight onto the management of a pediatric ischemic stroke, especially like ruling out the cause, which is very important in the pediatric age group? And if you do not find any particular cause, because there are a couple of papers that shows that there has been atherosclerosis that has been found in a single digit age, which is very surprising. So, what's your take on this very important topic?
Okay, thank you for the great question. Actually, the pediatric stroke is quite rare, right? So
Yes.
we have the only couple of the experience perform the thrombectomy for the patient. The result is quite good, but maybe the etiology of the clot is quite different from that in the normal the patient. So we need to care about that the comorbidities for the stroke patient. But the in my experience, the result is quite good. And also the some patient and some paper establish the effectivity of the thrombectomy for the even the pediatric patient.
So that's very that's great, sir. Thank you very much, because even myself, we haven't seen any of these cases before. I'm basically in neurosurgery, but we do not deal with ischemic stroke. But still, there wasn't any record. But recently, just a couple of days ago, I actually came across a patient who is basically in a pediatric age group, and this is very much surprising. And I believe that in that case, knowing the cause, like you have very nicely mentioned, is very important. So also there's another topic of our interest is that the management of ischemic stroke in patients with moya disease, because I believe that it's very risky to go the IVTPA and also tubectomy in those.
Yes. The moyamia patient is, mostly found in the Japanese or Asian, Asian people. And actually, for the acute stage, the thrombectomy or the endovascular treatment for the moyamia patient is not established. We can just do the medical therapy, perform, let's say aspirin or something like that. And for those patients, we always perform the bypass surgery. And this is a very, we published a great evidence that bypass surgery is much effective for the patient, especially, the pediatric or, the young adult cases. So endovascular treatment is not established. So, you should not never no treatment.
Yes, it's quite a risky thing that we know about. Thank you very much, sir, for your very comprehensive answers, which means a lot to us. And so there is another question that I would like to just suggest as one more question, sir. There is from Dr. Hussein Senonjo from Uganda. He's asking CTA versus MRA in identifying intraluminal pathologies leading to ischemic strokes. What is your take? Would you prefer CTA over MRA in identifying intraluminal pathologies?
Okay, thank you for the great question. I guess, the imaging is depend on the country or the institute you have the machine. Maybe the, Japanese society has a lot of MRI machines, so the MRI imaging, the analysis is quite normal to check the status of the ischemia of the embolic, to check the embolic, the location. But in general, in the world, the CT scan is very famous, CT or CTA. So maybe in your country, CT is maybe more, the commonly used, maybe, right?
Yes, exactly, sir. But I believe that for like I've mentioned before, for the pediatric patients, sir, I believe that you would prefer to have an MRA over a CTA if you are going to have an angio.
Yes, yes, yes. It depends on the maybe the pathology or something. But again,
Yes.
in the ischemic patient, the time is very important. So maybe if you can, you don't waste the time performing the MRI imaging. In Japan, we can perform the MRI imaging very quickly. That's why we perform the MRI rather than CT. But in general, CT is quite quick. So that's why the CT imaging is widely used in the world.
Yes, exactly. Thank you very, very much, sir. Again, sir, thank you very, very much, sir, for your time and for sharing your kind experience with us, which means so much to us. This is okay, sir. Would you allow me to unmute one of our attendees?
Say again?
Sir, would you like me to allow one of our attendees who has raised hand to probably talk to you? Would you like me to unmute him?
Like to what?
Unmute him. He wants to talk to you. One of our attendees has raised his hand.
Okay,
Would
okay,
you like?
okay.
Thank you very much, sir.
Go ahead.
Dr. Kabulo is my friend also, and he really wishes to say something.
Thank you so much, Dr. Nuru. Thank you for organizing this great webinar, for inviting great professors. So we always appreciate what you are doing to neurosurgical community. So congratulations, keep it like that. Yeah,
Thank you having a time.
thank you. Professor, thank
Very
you so much
appreciated.
for your very Thank you so much for your very beautiful presentation. I really enjoyed your presentation. And I don't know if I missed something. I wanted to ask, do you sometimes perform bypass for ischemic stroke? If yes, which case and when do you do it? Thank you.
Say again, the Moyamel patient, what do you, what? Sorry, I cannot hear the, with the internet access. So it is, can you say again, one more?
Dr. Kabulo, will you please repeat your question? I
Internet
believe
is
he
not so
wishes.
good.
I believe he wishes to ask that if there is an acute stroke, would you like to perform bypass surgery? And he's not particular about Moyamoya's disease. He's asking in general, do you have any case where other than Moyamoya you have to perform a bypass surgery for
Ah,
stroke?
okay, got it, got it. So the, in, let's say the atherosclerosis, based maybe, let's say the M1 severe stenosis or something. So the bypass surgery is not established in the world. So some clinical trial failed to the benefit of the bypass surgery. So actually in Japan, we mostly perform the bypass surgery for the moya-moya patient and sometimes for the complicated aneurysm patient. Maybe sometimes we do the clipping or coil embolization with bypass. So yes, okay,
Thank
it is
you.
okay.
Thank you very much, sir. And I believe so. There is also a topic of interest, which is, which is very quite debatable, but the intracranial atherosclerosis, the ICAD, and also the intracranial dissections. I think these are also two very important topics that, we have taken a lot of your time today. I think it's a whole different topic.
Yeah. But
So,
anyway,
sir,
the for M1 stenosis, we sometimes perform the PTA or stenting. That's very effective beyond the
yeah.
bypass surgery.
That's incredible, sir. And sir, what about there are cases where we do have this criteria for the extracranial atherosclerosis, the carotid atherosclerosis, and where asymptomatic and symptomatic, and we have to go through this percentage of stenosis, everything, which is I believe I've been asked to keep it very basic, but we have gone through a little bit more of them because we have got attendees from all over the world and at every level of training. But I believe, sir, what do you believe in I because what we've been told and what we know is that extracranial stenting isn't that much, that it's only reserved for a particular indications and more endarterectomy might be more preferable. So what's your take on this?
Yeah, that's a great question. The device is advancing as well.
Yes.
So even in the near future, even the patient shows the barometer plaque in the extracarotid artery, uh, maybe the result of the stenting is getting better. So that's why in Japan, penetration of the carotid artery stenting is increasing. So now we do the direct surgery for such cases, but actually the number is decreasing in my institute. And also the patient prefer, less invasive surgery. So you don't want to be open the, skin.
Exactly. So many people, they are very much, apprehensive about the surgery. So they would not prefer to go to undergo surgery. Even if you say that it's a better option, they would never do this. But sir, for those who are already asymptomatic, there is some sort of apprehension when you are doing this thing. Like you have said that the advancement in this technology is quite rapid. So I believe there would be better options for us that will be available for every one of us. And I think the people also like to insert filters and anything to prevent distal embolization when they are performing stenting of the extracranial carotid. I believe that's some option that could be considered, something like that.
So we perform currently we don't do any surgical
Prevention.
yeah, for the asymptomatic patients.
Yes, exactly. Because this is very risky, but many of the people would they are much more interested, especially those who have a family history back there. So they would be like all the time they wish to undergo this thing that even if they are asymptomatic, they come across this knowledge of having the stunting, and they really wish to undergo that thing. Which is, I think, here comes the role of education of the mass population, that this is not the right thing to do. But many people would be seriously, many of the people even contact me asking about this thing, that we have a family history of stroke, and that we are asymptomatic, but we want to get a stunt done or something like this, which is very, sometimes it is very hard to consult the patients that it's not the thing that to go for unless there's some really serious requirement. So again, sir, thank you very, very much, sir, for your time and for your talk. Sansai Hori, it was an honor to welcome you today. And I hope
Thank
to
you
see
very
you
much.
again
It's
soon.
my pleasure.
Thank you very much, sir.
Okay.
Thanks so much, sir. I think we wrap up the session for today. I'm so grateful to Professor Nobutaka Hori for his time and for an amazing lecture. And I'm also very much thankful to all the attendees who attended this session today. The session will be available on my YouTube channel, so you can go through it again in case you have any, everyone wants to go through the lecture again. And sometimes there are certain points that you have missed or something like this. So again, thank you very much. And this lecture will be available. The future lectures will also be hosted. And again, I want to reiterate that these are totally free of cost to attend. So don't hesitate to share it with your colleagues as well, because knowledge is something which is priceless. You cannot put a price tag on the knowledge. So we owe this to all these teachers who spare time for education and for training and lecture, and we cannot say thanks to them. We owe them so much, and what we owe them is our practice. We owe them, and we can pay them through improving our practice and promoting more education to our colleagues and our juniors and our seniors. So again, I think that many of us might have benefited a lot from this today's session. So again, thank you very much, sir. And time to wrap up the session. So goodbye, everyone, and see you again soon. It's not a goodbye, so it's a series. So again, thank you very much. And sir, Professor Hori, I will certainly have the honor of inviting you again to one of our future shows as well. Thank you very much, sir. Everyone, have a wonderful rest of the day.
Thank you very much.